Welcome. This training is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website at NHADACA.org within our webinar library. After completing this training, please complete the quiz and evaluation if you're interested in receiving a certificate. You can find the quiz and evaluation on our website next to the Watch Now button you selected to view this webinar on our website. If you're a member of NHADACA or NADAC, the certificate for this webinar is free. If you are not, the fee is $15. You will receive a certificate worth 1 CE once you have completed and passed the quiz and paid for the webinar, if applicable. Through the New Hampshire Training Institute on Addictive Disorders, this one-hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Drug Use Professionals, as well as NBCC. If you have any trouble viewing the webinar, audio problems, or any other technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to training@nhadaca.org. Thank you, and now the training.
Okay, so we're going to talk about group treatment for substance use and really talk about how motivation and the process of change interact in groups as kind of we think about individuals mostly when we think about motivation. So we're going to try and think about that. I do have some royalty arrangements. I've just, full disclosure, with Prevention Research. I do have I'm a co-author on the group therapy manual I'll talk about later, and I'm on the advisory board for Westbridge. So when we talk about group therapy, we have a group of people, but the whole point is, what are they doing? And what's going on in this group. The challenge is that most treatments have been developed focusing on individual and use techniques to help this individual to change. However, many providers deliver the bulk of their treatment in group format. And there are some there are some very specific group, mostly from the psychodynamic perspective, some from things that Yalom has done in terms of what group does and all of that. That's more conceptual about what group is, but the actual therapy, group therapy, is not a treatment. It just denotes the number of people in the room, not what specific type of treatment is being done. So you can do group therapy. I mean, I've been in Gestalt groups, psychodynamic groups, CBT groups. So you can have groups, but it depends on what you're doing in the group. That is actually what the treatment is, not just group therapy. And I think that sometimes is, people go, oh yeah, I went to group therapy. Well, I have no clue what you did. So there are differences. I mean, the individual treatment is tailored and focused on the individual. There's lots of talk time. It's difficult to come and not participate because you're sitting there with the therapist. That's true even for couples therapy. It's easier to explore more historical issues in individual, and there's a lack of peer modeling, and usually there's a single support person, that's you as the therapist. So we focus a lot on the therapeutic relationship in the individual treatment. For group, we have multiple individuals. It's really focused more on the communality. So what do these people share and how to share among that group? So if you're trying to create a group, unless you're doing individual therapy in group, you're trying to create a group that actually has some cohesion a lot of times, and at least has camaraderie and communication. You have less talk time because you're trying to make sure that everyone can talk. You have, in group, the individual can actually avoid active participation. You can sit there and just not say anything. The group leader has multiple histories in the room, so you don't just have one, you have really a bunch of different people and histories, and so it's sometimes hard. Sometimes we did group when we were teaching group therapy to do it and have a co-therapist, because the one who's not talking has kind of more of a sense of what's going on in the room. There's the good pieces of that is there's more modeling possible, so they can learn from one another, and there's more support potential in group. So those are some of the differences and similarities there. However, the goal of both individual and group treatment is essentially the same. Both are trying to motivate and activate change. If we have substance use groups, disorder groups, then we're talking on substance use, but there's also other problematic behavior. And even in substance groups, you talk about other kinds of problems. So groups often have very specific change targets. Sometimes we have domestic violence groups that a colleague of mine runs. There's post-traumatic stress groups. There's mindfulness stress reduction. There's mindfulness smoking cessation. There's relapse prevention groups. So although individual treatment may have a broader range of targets than the group, because often the group does try to cohere around some kind of a problem. So the challenge, I think, for everyone thinking about group is how to combine group and individual approaches. So I'm going to focus first on the change piece and then go back to the group. So where should we focus when we're trying to get individuals to change, whether we're talking about individual or group treatment? Well, the research really has focused on areas that I think have not always been as fruitful. The types of treatment, we've had a lot of research on treatment types and saying, okay, well, this CBT is better than ACT or DBT or better than psychodynamic or better than behavior therapy. And we've done a lot of research comparing therapies. We've done a good bit of research on the therapist characteristics. What does a therapist have to do? Empathy and warmth and a lot of Rogerian kinds of focus on the therapist. We've also focused on the therapeutic relationship, and there's been work on the working alliance inventory and the bond and the tasks and the goals and how integrated or collaborative are the therapist and the client in terms of some of these, the therapeutic alliance. The most of that research has really been focused on what we do. And so I think the problem is that most of the active mechanisms are related to individual process of change. It's the individual's motivation, intention, commitment, language, efficacy, all of those kinds of things are really what makes people change, not just what we do. It's what they do. And so that's been the work that I've been doing over the last 40 or so years, is really trying to understand that individual process of change and how does treatment and that process of change interact. So if I think about treatment, again, when we say how does treatment work, most of our research is focused on the therapist, the treatment, relapse prevention, all of these different kinds of things. But what if we look at it another way? What if we focus on the client first and what the client's doing and see environment and treatment and support as the background that helps encourage those processes? So that's the perspective I'm taking today. In group, what we're going to be doing is not thinking merely about what am I doing, but also what is the client doing? And how do I engage these kinds of processes and their motivation and their self-regulation and their efficacy, and deal with their multiple problems to help them make the changes that they need to get into recovery and seek the support systems that would help them do that. So let me kind of share a little overview of my view of behavior change. This model originally kind of came out of psychotherapy. That's the trans-theoretical model. I'll talk about that a little later as well. It came out of psychotherapy. It was tested, and a lot of the original work was done on helping people quit smoking, so nicotine addiction. But it soon went all over the place, because if you think about all kinds of health promotion, disease prevention, and treatment, and interventions of any kind, prevention as well as interventions for treatment or recovery, they all require some behavior change. So it doesn't matter if I'm talking about cancer. So in all of these areas, this stuff has, the model has been used. And the idea is that if you're going to change something, but you have to do different things. So sometimes we're asking people to start new behaviors. Sometimes we're asking people to stop problematic behaviors. And sometimes we're asking people to modify their current behavior. Diet seems to be a bellwether of this kind of thing. You don't start and stop eating. You modify how you eat. And modification may even be more difficult than initiation and cessation. And if we think in the bigger picture, it's really about what we're trying to do is have individuals live in this moderated, self-regulated behavior pattern. We want people to be able to manage their lives. We talk about it. We want people to be able to manage their behaviors. And so, and that includes starting, stopping, and modifying different behaviors that we are engaged in. And a lot of times we start with some moderated, self-regulated pattern and we go to excess. And addictions are a clear problem of excess. And so what we then do is say, okay, well, but when you go to excess, usually you get some feedback from the, even if you just overdrank one night, the next morning you kind of get the sense of, okay, well, there was a problem there. And that feedback is supposed to move you back into this moderated, self-regulated behavior pattern. And sometimes when you have things that you should be doing that you're not doing, so physical activity, for example, or, some sleep hygiene things, if you're not doing some of those things, then it says, okay, well, let's get back up here and start doing them. And that's really what's going to help you with wellness and health and recovery and all of those things. So you want to go here. Sometimes when you believe that you cannot move back in here, so that's what happens a lot of times with our drugs, is that and the substances, is that, well, with the addictive behaviors, they become so excessive and so problematic that they really kind of, you can't go back to a regulated self-regulated behavior pattern. And so we say, okay, well, you have to abstain. We think that where you need to go is, because you can't manage this with this particular behavior, you need to stop that behavior completely. So we have this model kind of helps us to understand where all of this change that we're asking people to do fits. And we've done all this. This model has been studied with initiating all kinds of health behaviors, condom use and medication adherence and physical activity, et cetera, et cetera. It's been used in modifying behaviors. So we've talked about reducing caloric intake, drinking in moderation, drinking and driving. All of those have used the stages and the processes of change model. And then it's also been used in stopping health-defeating or undesirable behaviors like tobacco use, substance use, alcohol, domestic violence. All of those have also looked at how to think about the process of change in these groups. So that's the background in terms of this. You probably missed it over the weekend. There was a large research study that came out from the National Cancer Institute that says that they discovered that watching television more than 1 to 2 hours a week causes brain cancer. So the question, I think, for you, okay, now that you know this information, how many of you would stop watching TV immediately? So if this were a real study and I were going to try and get you to do this, how would I get you to do it? Well, people start, stop, or modify behavior voluntarily only when they become interested and concerned about the need for change. They become convinced that this change is going to be in their best interest and it's going to benefit them more than it's going to cost them. So as you saw in the example there, if somebody says, okay, I've already done this, it's, I enjoy my TV. No, I like it too much. The benefit doesn't, the cost, it doesn't overwhelm the benefit. And so basically you're not going to get convinced. So you have to become convinced that the change is in your best interest. Then you've got to organize a plan of action and get committed to implementing that plan. And then finally, you've got to take the action. You've got to do something about the TV, and you've got to keep it shut off or whatever you're going to do to make the change and sustain the change. You may need to get rid of some TVs so that you're not tempted to do this or whatever. So you're going to have to kind of do this. This is what you would need to do, and this is what people do when they change voluntarily. Now, I say that voluntarily on purpose because I can make people stop doing certain things if I have control of some of the reinforcers or the punishers. So if you guys stop at a stoplight, sometimes it's because you think, oh, it's really for everybody else, but it's also, I don't want to get a ticket. And if I had the good jail, I could stop people from using drugs, because I could put people in jail and stop them from using drugs. But stopping a behavior is not the same as changing a behavior. And that's a real critical piece. This is about changing a behavior, and voluntarily, you're invested in it. Because often when you're forced to make a behavior change, as soon as nobody's looking, you will kind of not pay attention to that behavior change, or you'll go back to the old behavior change. And that's been the problem with prison and rehabilitation. We put people in prison, we don't necessarily get them to change their behavior, and then we let them out. And basically, while they're in prison, they're not doing some of the things they did, but as soon as they get out, they're back in their environment and they do some of the things. So this is what we're talking about in terms of change. And this is actually what the stages of change are. So I'm sure that most of you have heard of the stages of change if you're doing clinical work. And the stages are two. There's two pieces of the stages. There's the labels, which I think are helpful and interesting. Calling somebody in pre-contemplation instead of unmotivated ne'er-do-well is better to call them in pre-contemplation and just respond to the fact that they're just not interested in change, contemplation or thinking about it, preparation, preparing, initial change, and then long-term change. So those are the labels, but the labels aren't the most important piece of the stages. It's the tasks that are critical. So the client needs to figure out their level of interest and concern about this particular behavior change, or about the current behavior they're doing and the behavior they need to do to change that behavior. They have to do pros and cons here and make a decision. Then they have to get committed and make a plan that's effective and acceptable. Then they have to implement the plan and revise it. And then they have to integrate the change into their lifestyle. So basically, these are the tasks that you're working with people on in group or in individual work as they kind of change behavior. Now, there's some misconceptions about stages. Stages aren't boxes. They're not things that are easy kind of, okay, let's put somebody in the pre-contemplation box. No, they are states. They represent tasks that can be completed more or less. So even a person in pre-contemplation, we can't say, oh, they've never thought about changing that behavior. I mean, they may have had some thoughts about doing that. I mean, when we do some research in the smoking area, even though people are in pre-contemplation, which means that they say, I'm not seriously thinking about quitting in the next 6 months, many of them will have thoughts about quitting. Yeah, maybe down the road, when I have children, but, in a couple of years, maybe I'll stop doing this or whatever. But they're just not thinking about change or seriously considering change right now. So they're in pre-contemplation. So don't be rigid about having to kind of this person's in pre-contemplation. And I have had people who said, okay, we need to have groups for pre-contemplation. I'm going, well, that's great, but what if the person then moves to contemplation in the group? You need to kind of think about how people move and that people are moving. If your group is working well, people are moving through some of the stages as they work through their problems and go there. The other thing is, it seems like it is a logical sequence of tasks. So those 5 stages or tasks or whatever are key, but they're not followed linearly. So oftentimes you'll see people move back. Some people go into contemplation and go, no, I'm not doing this. And they go back into pre-contemplation. Some people get stuck in contemplation, or oh, I'm preparing for something, but they always are preparing, but they never get to do it. And there's also relapse and recycling, and we'll talk a little bit about that. The other thing is that stages are behavior and goal specific. So it's really important for you to kind of think about the behavior and the goal that that person has in their mind to really assess what stage they're in. Because the stage of change for cutting down on a behavior is different from the stage of change for abstaining from a behavior. And we learned that the hard way, because people go, well, I'm in action, and go, yeah, well, you're still smoking. Well, I'm only smoking 5 cigarettes now. Okay, so they're in action for cutting down, but often then that means they're in pre-contemplation for abstinence. It's not always a rational or completely conscious process. There's a lot of things that work on us that kind of are in the back of our mind, we say, or implicit cognitions that influence this thinking and how I'm going to do this. And there's some emotional events that really trigger change, and it seems like it comes out of nowhere, but people have been thinking about it for a while, and then this emotional thing happens and moves people. So that's also why week to week, from an individual or group therapy, you can't, just because they were in this stage last week doesn't mean they're in this stage this week. I give the example of somebody goes, so no, I'm not going to, I'm going to keep eating the way I'm eating. I don't care about that. I mean, yeah, I've got some risk for a heart attack or whatever, but it's not a big problem, so I'm not going to do anything about that. And then during the week, a friend of theirs who's a golfing buddy has a heart attack. And all of a sudden, there's a wake-up call. And the person kind of begins to kind of feel uncomfortable. And that emotional experience helps move them toward change. So values, emotional reactions, implicit cognitions, experiences, all of these affect the engagement and completion of the stages. So that's why you have to see the individual in context. So this is the client-focused model of intentional behavior change. And it's a model. It's not a theory that has everything. This is how everything happens and has all the connections. It's a model, a heuristic model to help us think about change and think about what we are trying to do and what that individual needs to do to make change happen. And so the stages are probably the most known part of this model. The processes of change, however, are critical, and we'll talk about those a little bit later, because they're the mechanisms of change. They're the things that people do, and there's 2 sets of those, cognitive, experiential, and behavioral, that we'll discuss. So in the model, when we were working on the original stuff, we kind of talk about, what did people say? Oh, well, that's just smoking. And then we said, well, no, actually, when you got to think about smoking, you got to think about the whole process, the whole context of change. So we have a concept in the model called the context of change. And it says that you have to look around to see where there are resources or where there are barriers and other problems that can impact and influence the use of processes and the movement through the stages. So the context is the larger perspective of the individual and what's going on with that individual that could affect what they do and affect their completion of the stages, tasks. And then we have worked with a couple of markers of change that we call decisional balance and self-efficacy or temptation. So this is more early. We call them markers because this one is a marker of kind of movement or action or activity in these early stages. This one is usually in the later stages. So that's why we have this model that kind of gives us a perspective of how do people move from pre-contemplation. This is the area where we think about motivation. This is the area where we think about decision making. This is the area where we think about taking action. So there are different parts to the change process. And we have a decisional balance, like I said there. We have all of these cognitive experiential processes that work more in the early stages, and we have more behavioral processes that work in the later stages. So our challenge is to kind of think about what helps or hinders completion of the tasks of each of these stages and engagement in these processes to make this happen. We also have what we think of as relapse. So people who have started changing, go back and stop the change. And we originally thought about relapse as a stage of change, but it's not. What was really important is our understanding that relapse is an event, and that people go back into earlier stages after they make this change attempt that has not worked for them. And so the challenge is, even after relapse, to figure out where they are in this now about this particular change. And again, remember, it's goal specific. So where are they with this? Because people relapse and then go back and say, okay, well, I think I can drink socially. So they go back and they're in action for drinking socially, but they're really, usually they can't do that well, a lot of them. So when we think about successful change, we think about it like, people think it looks like this. Oh yeah, and the Nike followers will do that. Just do it, and you kind of get there and you do that. Those of us who work in the area of behavior change with either mental health or substance use issues know it doesn't look like that. It looks much more like this. It's a lot messier. So that's really what the process is, and this relapse and recycling is important. So we need to understand that, and especially in group, we need to have people come back who aren't completely successful. So we need to understand that the relapse process is critical to the change process. So again, you have this, people move back and forth. Relapse isn't a stage. Recycling is the reality, really. And there is some difference between recycling, which is a learning process. So each time I go through this cycle, I should be learning more and doing things a little bit differently, even if I'm not totally successful even the second time or the third time. You're hoping that all along the way you're learning something. There's a difference if somebody's just trying and failing. That's not a learning perspective. There's something wrong there. And usually what happens, if you think about people who kind of try, fail, is that there's something else going on. And you need to step back and look at the environment, because possibly they're going back into an environment that's not functionally going to help them to change. Or you look at the individual or the people around them. And you need to see, sometimes there's a mental health problem that person has that's undiagnosed. So they're not able to get through enough sobriety. And I was running an alcoholism treatment clinic. The doc said, well, I'm not going to put them on any medication for their depression until we get at least, a month of sobriety. I'm like, we can't get a month of sobriety while they have the depression kicks in and they start drinking again. So we need how about, can I negotiate a week? If I can get them a week without drinking, can you get them some medication? Because it takes a couple of weeks for the depression medication to take effect. So basically these folks are without really the support of the medication for a couple of months if you actually don't give it to them for a month. So we need to think about, how do we handle some of these redos, and where do we find that there's another problem out there that we need to fix or address to be able to do that. And I've been doing a lot of work on thinking about relapse and failure, and reading books on failure. Actually, there's a lot of books on failure, which is really interesting. And failure is not the opposite of recovery. Not trying is. So that's really a critical piece, even for groups that they know. So this cycle of change is what I think the model got to be known as, because people realize that people go through this cycle multiple times, a lot of times, before they're actually able to sustain change over time and leave this cycle of change so that they can change other things in their lives. Let's see. So the challenge is then, well, how do we understand relapse? So what's relapse? Well, relapse usually happens here because you have to start making a change for you to give up on the change, right? And I think of relapse as giving up on change. Not, I had a drink, or I had 2 drinks, or I hit a heroin. It's when you give up on change. Because in action phase, people slip and lapse and do that kind of stuff, but continue to work on that. So if relapse happens so often with so many different behaviors, it's not just a problem of substance use. I mean, John Norcross did New Year's resolutions research, and basically, it took people multiple years to make the same resolution to actually make change happen and to sustain the change. So it's not just addiction; it's really about change. And so what I've been thinking about recently and working on is it's really about doing these things well enough to support the whole change process. So when somebody relapses, it's not just about a cue that the person met that they couldn't manage. Um, if a lot of times what it is, it's about the decision. The decision wasn't strong enough. I could have a very strong decision, but if I have a weak decision and still go on and try to make change happen, it's not going to be successful. If I don't have the commitment to follow through, it's the first couple of weeks and months of a new behavior where people fail the most, because that's what the hardest. So if I don't have a lot of commitment to get me through the early stages of action where it's not really very reinforcing to do this new behavior, I'm not going to make it. And maybe the plan isn't good. And maybe I'm not prioritizing. Something else came up and I just gave up on change. So we have to do all of these tasks well enough to be able to sustain change and to make change happen and be maintained over time. So what's the keys to successful recycling? Persistent effort, repeated attempts, learning from the past, recovering from, for addictions, where the neuroadaptation, it takes the brain quite a good bit of time to re-regulate after having done this substance for a long period of time and changed our brains. We need to find support for self-regulation, because it takes a good bit of self-regulation to make change happen. And a lot of times that's the weakest thing that some of our clients have. So they have impaired self-regulation. So we need to figure out how to scaffold or support that. And we need to begin building a new life without the addictive behavior. The issue is never giving up. And this is something we do some work with pregnant women substance users. And we did some training about that and interviewed one of these moms who is now in recovery, and asked her, well, what would you tell other moms to do? And she goes, stick and stay. The first couple of weeks in treatment, I did not want to be here. But I stayed. And then I got over the hump and really got into recovery. So that's the key for successful change. So why are the stages important? Well, if you can identify where the stage the person is in and understand their motivation, you will know some of the tasks that they need to be working on. And you can develop strategies that can be most effective in helping them move forward. But again, you have to pay attention to where people are, especially in group, in these different stages. So this is exactly the question. So yeah, so I have a group and I've got people in pre-contemplation. I have some people in action. I have some people in contemplation. What the heck is going on and what do I do? Well, the one quick thing that I want to say before we go into all this is, I think when we set up a group, we think about who's coming into the group, what their problems are, and can they really benefit from group? Now, many times it's like, I don't know if they can benefit, but they've got to go to group because that's what we teach. That's what we do. We don't have enough resources to do individual with everybody for everything. So a lot of times we just bring a group of people together. The one thing I would caution is, if you, because I experienced it, is if you've got too many people in later stages of change, and then a bunch of people in earlier stages of change, it's really hard to put those two groups together, put those people together and get there. So my experience was the individual, we had a group and it was a post-discharge group from the hospital. And we were kind of having groups say, well, why don't we get these people engaged? Because some of these people weren't coming to group after the hospital. Let's bring the people from the hospital over to the group. But a lot of people in the hospital were in pre-contemplation for making changes. And then we had a bunch of people who were in maintenance for making the change. And it just didn't work because we brought them, and then the people in pre-contemplation from the hospital were talking, as they do, war stories. Oh, you think that was bad, I did this and I did that, and I had, and the people in maintenance are going, we want to go move on with our lives. We're in recovery. We want to kind of build new lives. We don't want to be talking about all the stuff we did when we were druggy and drinking. So you have to be careful that you don't make it too heterogeneous. And so, I would encourage you, and this is partly answering the question, what we've done in the group therapy manual, and I'll show you that a little bit later, is have a group for pre-contemplation, contemplation, and preparation, and then a group for people who are more in preparation, action, maintenance. And so you kind of have at least two groups that you could kind of work with. If you've got that many people and you can do this, that's the challenge always. So what are we doing? Well, if we have somebody in pre-contemplation, our challenge is to help raise doubt about the continuing their problematic behavior, increase awareness of risk and problems, help them do some self-reevaluation that will make them a little more interested in thinking seriously about change. And again, I think I would change this to kind of thinking seriously about change as contemplation, because that's where you're trying to help the person voice reasons for change. You're trying to help them. And this is where motivational interviewing kind of comes in. And you really, in both pre-contemplation and contemplation, motivation interviewing strategies are really critical to kind of helping people kind of evaluate, raise the interests and the thinking of the individual to help them evaluate and make a decision to change. In preparation, you're really wanting to help people develop their own personalized change plan and build their commitment for it. So you're trying to help them with commitment building. In action, you're trying to help the client develop relapse prevention strategies, adjust the change plan as needed. I mean, the challenge with action is people start taking action, but it doesn't always work. And by work, it means it doesn't sometimes feel good. They didn't realize they were going to go through this much withdrawal. There was all this kind of stuff happening. When the plan that they proposed is not working, most people give up the change instead of changing the plan. And that's what you need to do. You need to change the plan. If that plan's not working, find another way around it. And that's why slips are important, because a slip teaches the person that the plan isn't quite working as well as you thought it should. So let's see what we can do to revise the plan. So here you're helping them revise the plan and supporting the change that they are trying to make. And then in long-term maintenance, you're trying to identify strengths for long-term change, pride sort, help them with resolve additional problems, because once you change some of a key problem, there are other things that come in that you need to change. So when we think about that, okay, so we're now trying to get people to do things. Well, what's the client's work in making change happen, and what's the provider's task? So what's your job and what's the client's job, and what's the difference? From this perspective that I'm teaching you today, the client's job is engaging these processes of change and coping activities so that they can actually complete the tasks. The provider's job is to offer some strategies and services that can engage some of these processes, can help them and support them through doing the tasks that are needed to move forward and change. And I like this because it kind of identifies the different pieces of this. So we talk about a treatment plan versus a change plan. And a lot of people say, okay, well, what's the treatment plan? That's what's going to help make them change. A treatment plan has never made anyone change. Okay? The treatment plan can support the change, but the treatment plan is what you're going to do. It's what the provider is going to do. It's what the provider is going to give. It's the strategies, it's the services that we're going to do to help you. The change plan is what the client's going to do. And the change plan is always more important than the treatment plan. And the treatment plan always should be in the service of the change plan. And so that's the kind of thinking that you have to kind of have, it seems to me, to kind of really make the client the center of the change process and the change work that you're doing. So the mechanisms really are what we're supposed to be doing is engaging the client's mechanisms, encouraging the client to build and to follow a change plan that works for them. So in the model, we originally, and why it's actually called trans-theoretical, is we took principles of change from a variety of different systems of therapy. So that's what Jim Prochaska was doing in Rhode Island when we got together and start working on this. And actually my dissertation was trying to kind of understand, well, does what people do, or these processes of change, does that predict change? No matter whether you're thinking about self-change or doing different types of treatment. So in my dissertation, what I did was look at three different groups of people. Some people who quit smoking on their own, some people who went through smoke enders, which was an old cognitive behavioral kind of program for smokers, and some people who quit through SHIC. SHIC was a aversive conditioning program. So that was where you stayed in a phone booth and you smoked 5 cigarettes in a row and you had ashes around you and dirt, and it was trying to make it so aversive that you wouldn't want, that it was no longer pleasurable. Similar to what some of our medications do with like Chantix and stuff, which tries to turn off some of the pleasurable parts of the tobacco nicotine addiction. So I went and looked at those three groups, and it was interesting that there weren't differences in the processes for the most part. There were a couple of small differences, but they weren't really very different. And what I learned was that people said, "What do you mean? How important was this? You mean before I started to quit? You mean now that I'm actually quit? You mean when I was in the process of changing?" Because everybody had to be at least 1 month off to get into my research. So we realized that the processes of change, or these engines of change, really depended on where the person was. So processes then became, coming from these different treatments, became the engines that enabled movement through the stages. So that's how we see them. They're the client's engines, change engines. And that there was something about doing the right thing at the right time, that you had to do some processes, cognitive experiential processes, during early phases of the change process, and switch to behavioral processes as you moved into the later stages. So during recovery, the action stage focuses on the behavioral processes. So when you're actually in recovery and doing that, we need to kind of shift focus. So that's why motivational enhancement is really nice, and motivational interviewing is good, usually for the early stage stuff, and then more of the behavioral and the cognitive behavioral stuff is more important in the later stage stuff. So let me just quickly run through these processes of change. What are processes of change? Well, there's big names to them and whatever, and I'll go through those, but they really are just basic human experiences or activities that happens in the person in the context of their life. What we've done is identify distinct mechanisms that these processes are, but they often act in combination. So consciousness raising and self-reevaluation, I'll talk about those in a minute. The two sets of processes represent two critical types of activities. So the cognitive, experiential, emotional aspects of change and the behavioral aspects of change. So it's really important to realize that there's a pre-action and then there's action phases of the change process. And that's important because we don't want to focus just on thoughts and feelings. since thoughts and feelings are important, but without action, there's unrealized potential. One of the criticisms sometimes of some of the analytic process was, oh yeah, people who have been through 8 years of analysis know a lot about their thoughts and their feelings, but they act the same way, that they never change their behavior. Now, whether that's a fair criticism or not is another question. But that was something that people would say. They have a lot of realization, but they don't have any action. It's also not just action. So taking action, and there are a lot of people say, well, we'll try it, do it first, and then see if it feels good and do that. Yes, you can start doing some action, but without really the interest and concern, the risk reward analysis, and really making a decision that this is the behavior I want to do, usually that action doesn't last. So precipitous action without any kind of thought or feeling or whatever. So that's why we need both of these sets of processes to be activated for this process to work for the individual. And as I said, we have two sets of these. This came out of research. I mean, originally Jim thought about 5 processes happening at 2 different levels or whatever, and that just didn't come out. But in our research, we studied the processes of change and did factor analysis, and often in both, in smoking, in alcohol, and often in other behaviors, what you'll see is a set of experiential processes come out and behavioral processes. And these are second order. And then if you look at them, they're also related at a higher level. So a third order factor analysis connection. But they seem to be distinct, yet connected. So consciousness raising, I'm going to go through some of these on the experiential processes more than even the behavioral processes, but I'll do that, and we'll go through each of those processes. So consciousness raising, increasing awareness, emotional arousal, experiencing emotions regarding the behavior. Now remember, all of these processes are about the behavior. So it's just like, oh, I got really upset yesterday about X. If it has nothing to do with what you are kind of working on in terms of the behavior, it doesn't matter that you were upset about X. You were mad at your wife, but unless that's connected to, I realized that something was going on with, it's really about my drinking, then it doesn't matter. So it's really the processes as well as the stages are focused on very behavior specific kinds of goals and behaviors. And then you have self-reevaluation, environmental reevaluation, and something we call social liberation. Now let's go through those. So the process of consciousness raising. So it's the human experience of just becoming more aware of developing better understanding or a new knowledge or something. So it's at the heart of what we hope education to do. Right? Education tries to teach us about how to do some things, but it really teaches about information, knowing something, making us something that we're less aware of, more aware. So you're really increasing the awareness. Individuals have different learning styles. So part of the skill or the art of psychotherapy a lot of times and treatment is really kind of being able to kind of match how you deliver your information to the learning styles of the individual who's there. So they have different ways of processing information. So that's really part of it. And sometimes we actually use experiences. We ask people to go and have an experience and then see what that tells you. Does that help you understand things better? So I used the example of beer goggles. So in some prevention programs with both adolescents and college students and whatever, they put goggles on that simulate being drunk and have people do a simulated driving test and see how they go with the driving. And often they will they'll try and do that and think they're driving really well and start hitting things and doing stuff virtually, obviously, and realize that, wow, that doesn't work. I mean, sometimes people actually have done a course where they're supposed to drive around this course slowly with these goggles on. So after they come out and go, oh my goodness, I didn't realize that, that I would be this disoriented. We ask people to monitor themselves. Okay, go home and just see when this happens. Check and see when this happens. That's an information we want them to become more aware. Sometimes we have pamphlets and presentations and conversations that promote consciousness raising. So consciousness raising is really something that's all around us. The advertising is filled with consciousness raising. I mean, I don't know about you, but if you watch the news, almost everybody who watches the news must have a lot of different kinds of problems because all of the ads, you didn't know this, but now you know that there's this medication that you could use for your depression, for your psoriasis, for your weight, we have all kinds of things. And so some of that's really trying to get you to think about it. Some of it's really trying to get you to reevaluate whether you need it or not. And that leads us to the next one, which is the reevaluation one. So there are two reevaluation processes that we've identified. Self-reevaluation, so really changing the way I see myself in regard to the new behavior. It's about how I judge myself, my own personal values. So that's why it's a lot of reevaluation of my behavior, of what the change means to me. And usually there's comparisons with other people. And, again, you could do self-reevaluation to kind of keep you in pre-contemplation also. So a lot of people that I treated were kind of going, well, wait a minute. I can't have an alcohol problem or be an alcoholic because the people around me drink more than I do. So according to their standard, they reevaluate that they don't have a problem with alcohol because they're drinking less than other people. And in one feedback program we used to do, well, you say, yeah, you're right. You're probably drinking less than other people, but you are drinking with the 5%. There's only 5% of Americans who drink as much or more than you. And so that was a consciousness raising thing, but also kind of getting them to reevaluate how much they're drinking. So again, we try to kind of give experiences that help with evoking this self-reevaluation. And it happens in their own personal space. So if you have a group, it's not going to happen. Everybody might take this same information and reevaluate it somewhat differently. So this is about reevaluating it in relationship to yourself, self-image, self-concept, all of that kind of stuff. This is reevaluation in relation to the environment, which is the personal context as well as the larger environment. So there's values related to how it involves others, the social context, importance of others. And if you just pay attention, look, I mean, I know you're not supposed to watch TV because of the brain, but don't worry about that since it wasn't a real study. When you're looking at TV, look at the messaging that you hear on the TV. It's really trying to activate these reevaluation processes and really trying to activate some emotional experiences, some consciousness raising, and the self and environmental reevaluation. So look at ads, especially around global warming, the ads about tobacco companies are lying to you. Do this for your children's future. You want to take this medication because you're going to you're going to see your kids grow up. My marriage is going to be better if I can make this change happen. So there's a lot of different kinds of messaging that are really promoting self-reevaluation. Now, if you don't listen to the messages at all, there's no reevaluation going on. So it's the same in treatment. If the client's not listening to you, there's none of these processes that are going on. So the next process that we identified was emotional arousal. And this is really having strong feelings related to the behavior and the change. Remember, it's not just strong feelings. It's really got to be related to what I'm thinking about and what I'm trying to change right now. Emotions are interact sometimes with reevaluation, but usually this is a much more just a direct, compelling experience of strong emotions that that feels like it's driving me toward change. I mean, I've had a couple of examples. We had a guy who was quitting smoking, and he said he had to quit smoking because I said, well, what triggered your quitting smoking? He said, well, I was smoking and my 2-year-old ran up to me to give me a hug, and I had the cigarette in my hand. He ran into the cigarette with his arm and there was a burn in his arm. And he realized, oh, that's terrible. I can't do this anymore. And so the emotional experience of hurting his child with a cigarette was what really kind of pushed him over the edge in terms of decision making, and gave him the commitment to kind of make the change happen. So you also look around. There's many appeals to raw emotion in the social media. I mean, I don't know about you, but I get every day there's mail that comes in asking for donations for this or that or the other thing. And many of them have pictures of starving children or children with disformed or disfigured faces that this charity is going to help. You know that the shelters during the pandemic have for pets have kind of been evacuated because people have been taking pets in. But again, you know, many of the ads show these pets as being mistreated and needing a loving home and getting you and playing on your heartstrings. Glaciers melting are supposed to get us to really kind of become more emotional about that. So these all appeal to the emotions even more than the thoughts. And there are theories that believe that individuals are more influenced by emotion than just rational awareness or reevaluation. But I believe it's really a combo. And so you've got to get both of these things. And again, to make a deep decision, you've got to have reevaluation, but you also have to have an emotional investment. And then you have social liberation, which really is about the societal influences. So environmental and societal events that really involve the person recognizing and processing social cues and social customs. So society's offering policies, practices, punishments, prohibitions, anything related to my behavior. And once I become aware of that, it helps me to kind of think about maybe I need to change. So indoor smoking, that really pushed a lot of people to think about changing. The policy that you can't smoke in businesses or whatever. We just changed in Maryland the age to buy tobacco, so we now have tobacco 21. So that changed. The hope is that the kids realizing this is really getting really costly. I don't need to do this. So it's a prevention activity, but also people going, I'm not paying $11 for a carton of cigarettes or $20 for a carton of cigarettes. And that becomes part of the reevaluation or the reasons or the rationale for making a change. Alcohol-free New Year celebrations that AA sometimes puts on are really another thing that says, okay, there's support out there for me to have fun, but also not to have to drink. The social policies in action stages can really reinforce change. Social policies, if someone is in pre-action, sometimes influence decisional considerations, but some individuals in pre-action get angry about the restrictions. So sometimes in group, if you're talking about some policy changes that are doing it, or they're making it harder, or they're clacking down on drinking and driving and whatever, and why don't there's bigger things that they need to do? Why did they get on? You know, so people can get angry about some of the restrictions or some of the policies that stop them from doing some of the preferred behaviors. And we can see this in spades in our current societal upheaval around masks and vaccinations and other kinds of stuff. So interventions at the social level or societal level should also offer some opportunities and incentives to change and not just be perceived as punishing. So we're going to punish you. Punishment usually doesn't work very well to motivate people. It may suppress some behavior, but it doesn't motivate involuntary intentional behavior change. I mean, it may be part of the whole process, but it's not going to do it by itself. So those are the experiential, cognitive experiential processes of change. So the whole idea behind this is it's these processes, activating these processes in your individuals that's really critical. So your interventions should activate processes. The processes should help people increase interest and concern if they're in pre-contemplation. And that's part of what you're trying to do. Now, there's also social and environmental influences and life context that also spur some of these processes on. So like I said, a lot of times, yeah, we can offer smoking cessation, but if you burned your child, that's your own particular life context thing that happened that really moved you to use these processes and get motivated to kind of make a change happen in your smoking. So that would be the activating processes and generating interest and concern. This is decision making. Again, the interventions should spur the processes and the life context and social context to make a decision, to really think about this. Maybe I have to do this cost benefits analysis, and then finally to make a decision to change. So that's the idea behind the processes and how we have to kind of design our interventions to activate these processes. Yes, we want to be working with people on their decisional balance, but we really want them to do some self-reevaluation, environmental reevaluation, conscious raising, and whatever, to create a decisional balance that will push them to change. I'm going to quickly do the behavioral processes because there's a separate set of behavioral processes that include self-liberation, which is about choice and commitment. These two are really about conditioning. This is about reinforcement, and this is about relationships. So if we look at these, choice and creating meaning are really important functions. So making sure that the person realizes I have a choice about doing this or not. And I have to take responsibility for this behavior. Those are critical. And usually they were highlighted, and this is again why it's trans-theoretical, by humanistic and existential psychology. The conditioning and stimulus control are really about behavior therapy and conditioning. Pavlov's dog and all of that. And there's two pieces of it. If I'm trying to get somebody to change something or quit a behavior, there's counter conditioning, where I change the response, and stimulus control, where I change the cue. Now, stimulus control is used by universally, and actually AA has a lot of those things. What AA says, avoid people, places, and things. That are cues for you to drink or to use drugs. That's stimulus control. Counter conditioning is sometimes we teach people relaxation. So we're trying to teach people, giving them alternative responses to when I feel stress, so that I don't have to break the stress, drinking, stress, drug connection. I change that by kind of stress, relaxation, stress, meditation. And that's where a lot of the mindfulness kind of stuff has come in. It's a counter conditioning process. And then Skinner highlighted the importance of reinforcement and how rewards and reinforcement help manage some behaviors. So both for increasing desired behaviors as well as decreasing unwanted. So we would try and get people who were quitting smoking to put the money that they would spend on cigarettes in a jar. So every day they would pay, if they smoked a pack a day, whatever money was the pack a day, you'd put it in a jar. At the end of a week, you'd see how much money you had, which was substantial, or at the end of a month, and you'd go out and get something nice for yourself. So rewarding yourself for making the change, or, punishing the stuff that you don't want, decreasing the reward for the, it's not that important, or it's not that. So you really want to decrease the reward, not necessarily punish. And then helping relationship, Carl Rogers focused on that. This is support for specific behavior change. So it's not how many friends you have around you, because a lot of substance abusers have a lot of friends around them. It's having somebody around you that you can talk about the change, having somebody around you who can show empathy and affirmation and even some shared experiences about change. And so that's the power of the AA group and some of the kinds of interactions. And that's the power of group. You can help develop helping relationships in group with around specific behavior changes for that particular individual.